Good evening, everyone. I'm actually not from Mumbai, I'm from Bangalore. That's where our lab is located, but I think that was just an error in the program. So thank you to the organizers for giving us this opportunity to talk. And today what I'll do is talk a little bit about liquid biopsy as a technique and some of the recent papers which are showing how it can be used in lung cancer. So just to set the stage, liquid biopsy means a lot of things. We will be focusing on ctDNA, but of course there are a lot of modalities, a lot of things which are present in the blood which qualify for liquid biopsy. There's circulating tumor cells, there's tumor-educated platelets, there's microvesicles and exosomes. A lot of these are at various stages in research and may or may not have found applications in clinical use yet. ctDNA is the one which has a lot of applications in clinical use, so we will be talking about that. And we use NGS. There are different ways of course, analyzing ctDNA. So what we have here is that you can take a look at you can understand what are the mechanisms of mutations in the tumor. You can look at amplifications, deletions, point mutations. There's a lot of work that's also going on methylation patterns. RNA expression is something which you can see from exosomes. Protein expression is totally a different thing, but yes, in a way it does qualify as a liquid biopsy also. So what are the clinical use cases that typically one associates with the liquid biopsy? Early diagnosis is something that is a dream right now, not yet very well established, but yes, early diagnosis, early detection, rather. One of the major uses of liquid biopsy, or one of the advantages, is that it can look at, so in a tumor, as we know, you might have different clones with different variants. And in a solid biopsy, when you will take a look and you have an FFPE piece, you may have only a certain part of the tumor represented. So tumor heterogeneity is much better represented in a liquid biopsy. The other thing is that acquired resistance, it's not very easy to resample in a patient who's been treated already with some TKI or something. So it's much easier to resample. So acquired resistance mutations are well detected by liquid biopsy. The other thing, of course, is minimal residual disease, which is an upcoming field, not yet clear how much and what, but yes, that's another potential application. So these are the things really, if you have to go in short. Acquired resistance, a clear thing, as we know, T790M, etc. Then you have monitoring recurrence in some form, early appearance of ctDNA can probably tell you something about whether the disease is still there at a molecular level, which is not present in imaging, but you're able to see some signs of the disease before you can see it in any other form of progression, which is like imaging. And of course, you can, in some form, therefore, plan your treatment. So this is a theoretical picture. I don't think there's any longitudinal study right now which has actually tracked the levels of ctDNA in this form, but yes. So the way that this looks at is that, yes, there's a diagnosis, there's a treatment, then the levels of the ctDNA drop, then there's a monitoring post-treatment. Let's say you're doing this was a surgery or something like that, and then gradually if there's a build-up, this is recurrence because you're seeing more of ctDNA again in the bloodstream, and then you do another intervention, it drops again, and so on and so forth. So this is the hypothetical ideal picture. And what I'm going to just show you is some studies which have taken a look at some of these really aspects. So when do we use liquid biopsy then over solid biopsy? So like I said, testing for acquired resistance mutations, because you're not going to find them in the original biopsy and you're not really going to be able to biopsy again. Highly metastatic tumors where heterogeneity is a concern. So if you have multiple metastatic sites and you don't know which one to take, this is one of the things you could do. Tumors which are difficult to biopsy or resect, of course, as a primary mode. FFP blocks with tissue exhaustion. FFP blocks with poor quality DNA, which happens quite often. So when we get samples for solid biopsy for NGS panel, sometimes the quality is not good if the block has not been fixed properly. So in such cases, liquid biopsy would be a useful option. And cases where the primary biopsy is very old. So this sounds very good. It sounds like a really great option, and it is. In the end, I'll just talk 2 minutes about the product we're coming up with. But the thing to remember really is that when you have tumor sequencing in normal, you have a sensitivity. Most NGS assays have an LOD of 5%, which means if you see, if you can see 5 reads out of 100, then that's something which you can call out reliably, and that's usually enough because driver mutations do tend to fix in the population, and you can see it. Now, what happens in liquid biopsy is the signal is really, really diluted because there are very, very few cells in the blood. And so a sensitivity of 5% is really not going to give you anything. So your sensitivity has to be 0.1%, 0.5%, something in those ranges. So you need a very low sensitivity, low limit of detection. So when you need such a low limit of detection, you need to make sure that you don't have any false positives also, because you're saying that I have, let's say, 2 copies in 1,000 or something like that. So how do you know that's not an error? Because we all know any kind of assay is subject to error, just random noise. So any assay that you'd look at some point, whenever you choose one, you should look at how it's validated. One of the things, so this is what I've just put here. This is something, one of the things that's used to ensure that there's not much noise. This is unique molecular identifiers, UMIs, and these serve as molecular barcodes. So what happens is that there are read families. So if you can look here, it may or may not be very easy to read here, but these are one kind of family, this is one kind of family, and this. So this is one barcode, this is another barcode, and this is the third barcode. And so if something is present on all of the same read family, it's a true call, but if something is present like this sporadically, it's not a true call. So this is something which tells you that what's a real read and what's not a real read. So this is important, and any good assay should have this kind of method to remove false positives. The other thing that's important is you can have a bioinformatically calculated noise model, which, again, what it does is it looks at lots and lots of data and lots of reads and says, how often do I just randomly see a how often do I randomly see a mutant at this read? And if you see that, so you can calculate the error at that location, and if you see something that is substantially higher than that error, even if it's, say, 0.5%, I can say that normally the error is just 0.03% is when I really see variant at this read, at this location, then you can call it out. So long story short, I'm trying to say that there's much that goes on in trying to get an assay to be able to call out variants at such a low allele frequency. So that's about the assay. Now I'll go to the applications. So there are multiple clinical trials which are evaluating the use of circulating tumor DNA as a tool to aid therapy decisions. So we heard today lots of talks about adjuvant therapy and when should you give ALK inhibitors, when should you give EGFR inhibitors, and some of the talks did talk about whether cell-free DNA can be used as an indicator. So yes, it's not yet such a clear indicator, but there are lots of studies which are talking about it. And if you look at it, especially in NSCLC, they are looking at this. So basically, if you look at something like this, this is about EGFR mutations and looking at minimal residual disease to see after surgery. Only if you can see that there is a particular variant, that's when you should give an adjuvant treatment, or should you not give an adjuvant treatment. So the data for these is upcoming, and it'll be out sometime. But it's worthwhile examining this and looking at it in some patients. So just a couple of slides which are not for lung, and this is something which is, the reason I've put it is because it's an approval which has come only because of blood estrogen receptor mutants. So this was a trial which showed that even though you didn't have any radiological recurrence, it's only on the presence of blood estrogen receptor mutants, there was a switch in therapy, and you actually saw a difference in outcome. So what this means is that the presence of the mutant in the blood is actionable enough, and you can do something just based on the fact that you did see it, and even though you could not, so it says with no synchronous disease progression, you could see it just in the blood, and that was actionable enough. And the other very famous use case, that's the breast use case, and the other very famous use case is in colon, which is again similar to what is being talked about for lung, but a little different. So adjuvant therapy after stage 2, should you give it, should you not give it? So of course here there is a standard way of evaluating it, but which is based on lymph nodes, etc. But you could also look at it by first assaying the main tumor, and then after that looking sequentially to see if there's any mutation in the blood at all. And if there is a mutation in the blood, that means that this is a high-risk patient. So in this 2-year evaluation, ctDNA guided management was non-inferior to standard management. So this is another very clear use case. So in these two, it has been proven, and it is sort of coming in, I would say, in use. Now, in NSCLC, I didn't find an absolute clear use case, but now, nevertheless, I thought it's useful to point out some studies which are looking at it in some detail. So these are 2 papers, recent papers published in good journals, which are talking about acquired resistance to EGFR therapy. Now, we know about T790M, and we also know about C797S, which is, so TKIs have a very fixed, very standard mutation, and you could, in principle, look for any one of them. But what these papers show is that you can look at you can do a panel and look for, you find that there's actually more mutations. So actually, the figure is from this paper here. And they found lots of mechanisms of resistance, not just the standard EGFR C797S. And here you can look. So MET amplification is the most famous one, and it is present. But in addition, you find HER2 amplification, you find PIK3CA, you find so many. So if you look, you will probably find. So this is a good case for trying to use an LB panel and not an individual mutation-based technique. So this is BFAST, Blood First Assay Screening Trial. And this is something which is being looked at again, that you, instead of a solid biopsy, just do a blood directly for those people. This has so many arms for all the standard driver mutations. And results have been published for ROS1 positive NSCLC, and only using the BFAST trial, entrectinib, and patients who were treated on entrectinib only on the basis of their liquid biopsy results. The endpoints were consistent with data from that observed in patients from tissue-based testing. So liquid biopsy, so for instance, if you have patients where you cannot get a solid biopsy, liquid biopsy is a useful alternative. So this is another paper which is talking about benefit from immunotherapy. Again, that has been discussed this afternoon, and you all know more about it than I do. But what they're saying in this paper is really that the presence of cell-free circulating tumor DNA can guide the decision that whether you should give immunotherapy after chemoradiation therapy or not, and it will distinguish responders from non-responders. So they observed variants in multiple genes, so it's not just the standard EGFR. They looked at TP53, PIK3CA, etc. So if you have a good panel, that's something worth doing. And detection of ctDNA pre-consolidation ICI or early on in consolidation ICI was a strong predictor of progression. So that's this curve here. So those which where it was not detected, they did much better than the ones where it was detected. And patients in whom the cell-free DNA was not detected after the CRT, there was not such a significant advantage of putting them on additional immunotherapy. So in this paper, so what this paper seems to suggest that you could actually use it to decide who should actually go on immunotherapy and who should not. So these are, of course, early studies, but they point to the way that it can be done. Another such paper is liquid biopsy for ALK, resistance to ALK inhibitors. Again, there's some variants which are known, but in addition, now this paper actually found new, previously unseen variants. So just because you don't look for one or two by, say, droplet digital PCR, but you look for the whole thing by a panel. So these are lots of variants, and I've just put a few here. They've actually done in vitro studies to see to see their sensitivity, and they find that they are not sensitive to a lot of these drugs. So again, looking for more finds more and gives an idea of how you can treat these patients better. This is for recurrence. I'm almost out of time, so I will not talk about this too much, but I think this was talked about in an earlier talk today, that detection of ctDNA following treatment was associated with shorter recurrence-free survival. Similar concept, that if you see ctDNA after surgery or after any primary intervention, there's some of the tumor lurking around, and it could mean that there's likelihood of it recurring sooner than in others. This is another study of the same kind. So to summarize, liquid biopsy is an important technique that can aid in clinical decision making. Progress in the last few years has identified clinical settings that demonstrate clinical utility, and much work is of course needed. It's especially useful in tissues like for NSCLC where FFP biopsy material is limiting. Increased use and focus on liquid biopsy testing will yield additional data on additional scenarios in which it will be useful. So I'll just take the last 2 minutes to talk about our liquid biopsy product now. The reason that we are just coming up with one, and it's extremely useful in cases where the solid biopsy has, the DNA is not enough, the quality or the quantity is not enough. And of course, in some cases, like I said, for all of the reasons, if you want to monitor or you want to look at it. So we have a 74 gene panel for liquid biopsy, and we also have a combo for tissue and liquid biopsy. And it covers for all the cancer types, all the standard of care genes. It also covers additional markers for of clinical impact, like we heard, STK11, KEAP1, and those kinds. So it also covers the pan-cancer markers. We cover fusions as well. So yeah, thank you, and hope you found some of this useful.